Well, good evening, everyone. I hope you can hear me. And a very warm welcome to the Mathematical Institute for the Centre for Personalised Medicine's Annual Lecture. My name is Anneke Lucassen, and I'm Director of the Centre for Personalised Medicine, or CPM, a role that's both a huge privilege and great fun. The CPM is a multidisciplinary scholarship and engagement initiative that brings together researchers, clinicians, academics, policymakers, and members of the public to explore both the promises and the challenges of attempts to personalise medicine. I myself am a clinical academic. I'm interested in how the remarkable scientific and technological advances of the past 2 or 3 decades do, but sometimes do not, translate into meaningful benefits for individual patients and their families. The Centre, I think, is one of those classic Oxford collaborations, a partnership between the Centre for Human Genetics within the Nuffield Department of Medicine and St Anne's College. This gives us a rich, genuinely interdisciplinary milieu in which to think carefully and discuss topics that easily become polarised, and to answer not only questions like, can we do this, but also, should we do this? For whom? And under what conditions? We run a wide range of events and activities, and we are always keen to hear new ideas, so please do have a look at our website and get in touch if you'd like to collaborate. We're extremely grateful to our funders, the Stanley Home Medical Development Foundation. It is in that spirit that we are especially delighted to welcome this year's annual lecturer, Professor Trish Greenhalgh. Trish is Professor of Primary Care Health Sciences at the University of Oxford and an internationally recognised leader in interdisciplinary health services research. She recently served as the head of the Interdisciplinary Research in Health Sciences Unit, or IRIS, which is a melting pot of clinicians, social scientists, computer scientists, economists, philosophers, and more, coming together around practical problems in healthcare and doing, in her words, creative and wacky research to tackle these questions. That ethos, I think, will appeal to many of us here tonight. Trish originally studied social and political sciences at Cambridge before qualifying in medicine at Oxford and went on to train as a general practitioner. That dual background in the social sciences and in clinical medicine has shaped a career devoted to bridging traditional boundaries, bringing together clinicians, social scientists, policymakers, technologists, and crucially, patients and publics to address some of the most complex challenges in contemporary healthcare. Her work spans primary care, digital health, and health services innovation, with a particular focus on how technologies are introduced, adapted, and sustained in real-world practices. She has consistently shown that innovations are never purely technical. They are also social, organisational, and relational, and success depends on engaging clinicians, patients, and publics and systems together rather than assuming that an app or an algorithm will be able to tackle complex health problems. Trish has been a powerful advocate for person-centred care. She reminds us that evidence and data must sit alongside relationships and that the context in which data is gathered remains crucial to its usefulness. As healthcare becomes more data-driven, the human dimensions of care and that context question needs careful nurturing. For those of us working in personalised medicine, that perspective is invaluable. It challenges us to ensure that personalisation is not just about biology and biomarkers, but the context in which these arise and about people's lives, values, and circumstances. We need collaborative systems of care to support these values. Trish is a highly influential scholar, author of hundreds of peer-reviewed papers and many textbooks, including one that I think is now in its 8th edition, How to Read a Paper, which has guided generations of clinicians and researchers in making sense of evidence. Her contributions have been recognised with numerous honours, including an OBE and election to the Academy of Medical Sciences. It is therefore my huge pleasure to welcome her to deliver this year's CPM Annual Lecture entitled Personalised Medicine, a Primary Care Perspective. please join me in welcoming Professor Trish Greenhalgh. When I've stopped blushing, thank you so much, Anneke, for that very kind introduction, and also for explaining to me before people arrived about how the Centre for Personalised Medicine is kind of morphing from something that was quite genetically oriented to something that is much more interdisciplinary. So I sort of feel that, yeah, this is probably quite a good time to talk about personalised medicine from primary care. But I'd like to start by saying a few more thank yous. Thank you to all of you, the audience, for giving up the most amazingly warm, sunny spring evening. Thank you to St Anne's College and also, of course, to the Centre for Personalised Medicine for hosting this and the dinner that some of us are going to go to afterwards. Special mention to Fran Dakin, who made the connection between me and the CPM, and also to Thea Perry, whose attention to detail in getting us all in this room with no hiccups has been nothing short of phenomenal. Yeah, I think so, really. Brief mention of my own college, Green Templeton, and also my department, primary care. And thanks also to the funders of my research. I haven't put all of them here, but these are the main ones right now. And finally, to people. Look, when you give one of these big lectures, you inevitably get portrayed as this lone hero. But the reality is that what I've got to say to you today has been shaped by countless conversations and interactions with so many people, too numerous to mention individually. These are some of my students. Let's face it, if any of us could do this on our own, we wouldn't need Oxford, would we? So there's probably someone in this room that actually doesn't really know what primary care is. So I'm going to start off with a few definitions. And this is a very popular one from Barbara Starfield. She defined primary care as first contact care, accessible to all, delivered by generalists, undifferentiated by age, gender or disease, and relationship-based and longitudinal. And what Barbara showed was that in any country, the stronger the primary healthcare system as defined by these features, the longer people live, the healthier they are when they're still alive. The smaller the gap between the rich and the poor in terms of health outcomes, and the lower the overall costs of healthcare. Now, what Barbara didn't show was that those relationships were causal, but those of us who work in primary care like to think that they are. Now, if you're thinking, hey, wait a minute, my GP isn't as accessible as he or she used to be, or wait a minute, I no longer have the kind of relationship-based care that I used to have a decade or two ago. I hear you, and I'm going to come back to that because that's an important thing at the end of this lecture. Another definition. This is from Julian Tudor Hart, who was a GP in the Welsh Valleys, friend of Nye Bevan. Primary healthcare is doing simple things well for large numbers of people, few of whom feel ill. Now, almost all of you in the last few months will have visited your GP surgery for something. Maybe to get your blood pressure checked, maybe to get one of the kids vaccinated, maybe because you found a lump or a bump or you've developed some kind of symptom that you're not too worried about. You just want to get it checked out. So you go along to your GP, or perhaps these days you might see a nurse practitioner, and most of the time what they will do is they will take a look at you and say, yeah, that's probably nothing to worry about. Here's some cream, here's some tablets, come back in a month if it hasn't got better. Very occasionally they might say, oh, I think I'd better get you checked out at the hospital, and they will then refer you in to secondary care. And once or twice in your entire life, your GP will say, gosh, we need to refer you under the 2-week wait. It's really urgent, or even put you in an ambulance and send you into the emergency department the same day. Now,
this gatekeeping function, fast-tracking the serious and the urgent stuff into secondary care and containing and managing the vast majority of stuff in primary care, that is what delivers the effectiveness and the efficiencies that Barbara Starfield and her team demonstrated in the early 2000s. Okay, one more definition of primary healthcare, which various important people in primary care have kind of tried to appropriate. In secondary care, diseases stay, but patients come and go. It's always the cardiology clinic, for example. In primary care, patients stay, but diseases come and go. Mrs. Patel comes today for her menopause, but in a month's time she'll be back, maybe with her rheumatism. And I do find this one a bit cheesy, but actually it's a good place to start thinking of what we mean by personalised medicine in primary care. Now, I'm going to give you 3 cases of patients seen in primary care, and I'm going to use those cases to theorise and take a look at personalised medicine. I want to tell you about the cases first. They're all based on real cases, but they've been fictionalised to protect confidentiality. For example, some of the diseases have been changed, the demographic features have been changed, the social context might have been changed. They all happened a very long time ago in a place a long way from Oxford. And the images are AI generated, but they are based on real people. And the first case is Holly. Now, Holly came to see me, and she was very excited because next week she was going to turn 4, and there was going to be a birthday party. And then about 3 weeks after that, Holly was going to be starting big school. And Holly's mum had brought her along because she wanted a letter. A lot of GP practices writing letters for people. And she wanted the letter to say that Holly was not allowed to do PE at school because of her serious heart condition. Now, I was a bit surprised because this picture is what you get out of ChatGPT when you ask it to give you a normal 4-year-old going to the doctor. But when I looked in Holly's medical record, sure enough, soon after she was born, she had been diagnosed with a condition called complete situs inversus, which is a condition where all your organs are on the opposite side of the body to most people. And that included something called dextrocardia, which is where the heart, instead of being on the left, is on the right. Now, Holly's mum said that all her life, Holly had had to attend Great Ormond Street Hospital every 3 months. And at each appointment, about 10 doctors all listened to Holly's chest and confirmed that the serious heart condition was still present. Holly was on no medication, and she'd had this really full workup at Great Ormond Street, which had shown that she had no coexisting conditions. But Mum didn't want to risk putting any strain on Holly's heart. So I thought for a bit, and then I suggested that maybe what Holly needed was a cardiac stress test, GP style. So I took her out of the room and I took her to the bottom of the stairs and I said, Holly, do you think you can race me to the top of the stairs? So up she scampered and came back down. And then I got her to race the medical student and then the practice manager who'd come out of her office wondering what all the commotion was about. And I then took her back into my consulting room and I made her a certificate. And it said, this is to certify that Holly has beaten 3 adults at the cardiac stress test, and there is no medical reason why she shouldn't do PE at school. And I also wrote to Great Ormond Street asking if Holly's cardiac checkup visits could be made annual, and if they could stress just a little bit more strongly to Holly and her parents that her heart was functioning entirely normally. So that's our first case. The second case is Amal and Deequa. So Amal was aged 13 and Deequa was 14. And they were the daughters of immigrants from a middle-income Muslim country. I saw them about 20 years ago, not long after HPV vaccination had come in to prevent cervical cancer. Now, these two girls were out of year since when they'd come to the UK, they'd repeated a year of school to catch up and learn English, which they now spoke fluently. Deequa was in year 8, and her cohort had had letters, another letter, saying that they were shortly to receive the HPV vaccine at school. But Amal was in the correct age group to receive the vaccine according to national guidelines. So I asked them what they would like to know about the HPV vaccine. They said nothing. We've looked it all up, and we've also found material in our own language for our parents who didn't speak as good English as girls. So I briefly asked the parents if they'd mind leaving the room. I had a private chat to the girls, but we soon brought mum and dad back in at the girls' request. Speaking mostly through their daughters, the parents said they wanted them both to have the vaccine, but not at school, because this could convey the message to their friends and their teachers that the parents were condoning early sexual activity. The girls agreed. They didn't want it at school either. So I had spent a while trying to persuade them all otherwise. You can imagine the sort of things I was going through, but they absolutely insisted that vaccination with the other pupils at school was impossible. They kept using the word impossible. So I wrote out 2 prescriptions on those green forms for the vaccine for both girls. They came back, and after surgery, I vaccinated both girls. 3 months later, I was invited to reflect on my practice in front of an informal review panel chaired by a pharmacist. I said, I'm very happy to reflect on my practice, but could you tell me what I've done wrong? I wonder if you can guess what I've done wrong. Apparently, there were 3 things I'd done wrong. Number 1, I had vaccinated a 14-year-old when national guidelines said that the programme would cover all girls who turned 13 that year. You will recall that it was the 14-year-old that had got the letter saying she was about to have it at school. Second, I had vaccinated a year 7 girl when local guidelines said that only year 8s were eligible. And I thought, you can get me on one of those, you can't get me on both of them. But third, and this was why the panel had been convened, anyone guess? Because I'd written out 2 of those green GP forms, the cost of the vaccine had ended up on the wrong budget. And that was what had triggered it. So I had to write a reflective statement and promise to do better next time, which I did. But it's worth noting that going back to Barbara Starfield's definition of primary healthcare, I looked after that family for many years after that. I saw mum and dad for various things, and I actually saw Amal and Deequa both go off to university. So it was a great relationship we built with that first encounter. And here's my 3rd case, Pierre. Now, Pierre, 78 years old, he's a fictionalized version of a research participant in a study that we did a few years ago of people with complex health and care needs. Actually, Anneke was telling me she was on the panel that gave us the grant for this a few years ago. So I'm going to read you an extract from the field notes. And I should say we got Pierre's written consent to put this particular version of him in the paper. So I'm quite happy, I'm comfortable with him knowing that I'm talking to you today. Pierre has high blood pressure, dizziness, a stomach ulcer, an eye condition that gives him blurred vision, for which he is under a specialist eye clinic. He has pain and stiffness in the shoulders and knees, and urinary incontinence following an operation on his prostate gland. He moves slowly and is in evident pain. He stops frequently to lean on furniture, and when he tries to make the researcher a cup of tea, he becomes so tired that he's unable to finish the task. Pierre's sleep quality is severely disrupted by his continence problems and shoulder pain. He wakes up about 6 times during the night, and he has to use a bucket at the side of the bed. For this reason, his wife sleeps in a separate room. He has little energy in the mornings due to poor sleep, and he attributes much of his dizziness to his sleep disturbance. Pierre's GP visits him regularly and has raised the possibility of him and his wife moving to sheltered accommodation. Okay, let's sum up where we've got to so far. Is the argument, this is a question, not a statement, is the argument then that personalised medicine in secondary care is all about diagnosing and treating diseases using ever more precise and sophisticated scientific techniques, while personalised medicine in primary care is all about that touchy-feely stuff of treating the patient like a person and giving them individual and family support? Well, there's more than a grain of truth in that depiction. But now I want to spend the rest of this lecture trying to persuade you that it's not that simple. I'm going to start off with this provocation by my old friend Tony Delamoth, who was deputy editor of the British Medical Journal. And he wrote an editorial in 2008. It was quite awkward because our kids were at the same school. And I said, what do you mean by writing that editorial? He said, is it wise to defend primary care solely by invoking its warm, fuzzy heart, beating away in its black box, far from the close scrutiny of all but its adepts? So the first thing we need to do is offer a more rigorous theoretical analysis of what Tony calls the warm, fuzzy heart of primary healthcare. What exactly is this personal touch that GPs are supposed to offer, at least on a good day? What's the evidence for it? So to begin to answer that question, I'm going to take you back 100 years to 1926, when a doctor called Frank Cruikshank gave the annual Bradshaw Lecture at the Royal College of Physicians. Now, Cruikshank was talking about diagnosis, but his conceptual framework applies to medicine more generally. And I have to acknowledge Professor Ian McWhinney, whose 1989 book on primary care actually referenced this lecture as a footnote, and I thought, oh, that looks interesting, and I dug it up. So he had the idea. Okay, so Frank Cruikshank asked his audience to recall two ancient schools of medicine. Incidentally, they weren't medical schools. They didn't have medical schools in those days. They were schools of thought. Now, both of these schools of thought, according to Cruikshank, originated in ancient Greece. And as you can see, the cities where they were located are now in ruins. One system was called Cnidian medicine. Hope I'm pronouncing that right. And it was associated with a tradition that emerged in Cnidus, which is now in Turkey, apparently, and linked to the philosophical work of Plato. Sorry, we're going to do a bit of philosophy tonight. I hope you don't mind. The other school was called Koan medicine. It was associated with a tradition in the city of Kos, and it was linked to the philosophical work of Aristotle and the writings of Hippocrates. So I think I need to, before I go any further, to acknowledge that some historians of medicine have questioned whether there really were two contrasting approaches to medical knowledge in ancient Greece. So there's a historian called Wesley Smith who says these alleged differences between this Cnidian and Koan medicine are a figment of the scholarly imagination. And when I read that, I thought, well, that's a pity, because I've written a whole lecture around this. But there are other historians, notably Ian Loney, who says, well, Smith is kind of correct that there's no direct primary source evidence of these two schools. But the more interesting thing is why the story about these two schools of medicine continues on. So I'm going to put that question aside for now, but since this is Oxford, I'll look forward to the classicist among you challenging me afterwards. But it doesn't really matter whether these happened in ancient Greece or not, because these two different approaches to medicine are very much alive and well now. And so I think we'll put the historical account aside for the bit, and we'll just pursue what these two, either schools or alleged schools, were all about. Take a look at this famous fresco painting by the 16th century artist Raphael. It hangs in the Vatican, and it's called the School of Athens. And the School of Athens represents philosophy. Now, right at the centre of this picture, you can see those arches, and underneath the arch, the bottom arch, are two figures walking forward, deep in conversation. There's Plato on the left, and there's Aristotle on the right. So let's bring them forward. Plato's philosophical position, at least for the purposes of this lecture, was that abstract ideas, which he called forms, are primary. That is, they're the most important things we need to focus on. Particular cases of anything are instances of these abstract forms. And Plato liked forms because he saw them as universal and unchanging and kind of pure. He didn't like instances because he saw them as variable, unstable, imperfect copies of the forms that are in our heads. And Plato believed that knowledge, which he called episteme, is based on grasping forms. He saw that kind of knowledge as superior to what he called opinion or doxa, which was based on data from our senses. Now, Aristotle, who was once a pupil of Plato, had a very different philosophical perspective. So he believed that universals, these abstract ideas or forms, don't really exist in a separate realm. They exist only as instantiated in particular substances, particular cases. So Aristotle said that knowledge begins with perception, right? We encounter this person, this illness. And he distinguished between knowledge, episteme, skill, techne, and practical wisdom, phronesis. And he was particularly interested, as I am, in phronesis, the wisdom to deal with a concrete situation in a way that is sensible and ethical and effective. So coming back to Cruikshank's famous lecture on diagnosis in 1926, he was making a major distinction. A medicine based on the teachings of Plato would be focused on the abstract, and a medicine based on the teachings of Aristotle would be focused on the concrete. Now, Cruikshank pointed out that in the Cnidian system of medicine, based on Plato's philosophy, diseases exist as abstract entities. So any individual patient can be thought of as a case of a particular disease. And in this system, risk, and I'm going to talk a lot about risk is depicted in terms of risk factors or risk states. For example, obesity is a risk factor for type 2 diabetes. Now, the work we do in medicine, diagnosis, treatment, monitoring, in this version of medicine is all about matching the patient's symptoms and signs to a particular disease or a risk state, and then selecting the right drug for that abstract form of the disease or risk state. So you can probably see how Cnidian medicine aligns quite well with the teachings of evidence-based medicine, and also with personalised medicine when it is defined in terms of gaining a more precise understanding of the patient's disease, for example, through genetic or biomarker analysis, and then tailoring the treatment to suit. Okay. Cruikshank depicted Cohen medicine taught by the Kos school as based on the philosophy of Aristotle and also on the writings of the Greek physician Hippocrates, who died a little bit before Aristotle was born. Now, this was a very different system of medicine. For these scholars, disease didn't exist independently of the patient who was ill. So each patient or illness was seen as completely unique. Risk was defined very differently. It's related to the individual and their circumstances, since different things are at stake in each case. So the physician, said Cruikshank, needs to consider the whole person in context, affected by their environment, changing over time, and take account of what matters to them. And as Cruikshank pointed out in his lecture, diagnosis for the Kos school was synonymous with, quote, the clear cognition of things present, unquote. That is, with a holistic, contextual, and interpretive approach from which treatment decisions could be personalised. This notion of things at stake is central to the kind of personalised medicine which we practice on good days in primary care. As anthropologist Cheryl Mattingly has put it, a central difficulty with clinical renderings of patients' sufferings is that in their abstractness, the world of the patient is left out. This world is above all a practical and moral one. in which patients have life projects and everyday concerns, things at stake. So let's see how these two different systems of medicine, Cnidian and Cohen, would have addressed our three case studies. For the Cnidians, Holly will be seen as a case of complete situs inversus. It's a rare genetic condition in which major visceral organs, the heart, the liver, the stomach, are mirrored on the opposite side of the body. It is, I am told, autosomally recessively inherited, so geneticists can correct me if I'm wrong, and linked to mutations in various genes. The Cnidians will be primarily concerned that Holly is at increased risk of transposition of the great vessels and ciliary dyskinesia. Don't have to know what that is, you wouldn't want to have it. So she needed to be checked out for these, and I'm very glad she was. It was very clear in her record that she didn't have them. Now, the Cohens would take a very different view of Holly. They would see, first and foremost, that while Holly's organs are flipped, she's functioning just fine and looking forward to starting school. But her status as a normal reception class kid is at stake. Despite firm exclusion of associated pathology, she's been over-medicalized. Some fun and games in the GP surgery can help reset the narrative and raise her parents' confidence to send her off to her new school without a doctor's letter. Now, it's worth mentioning here that because of what was at stake for Holly, because my goal was to reset the narrative, I never put a stethoscope on Holly's chest. I never took up the only opportunity I ever had to listen to a case of dextrocardia. Because if I had done that, I would have been playing into the narrative that the serious heart condition was still there. But I got something better. Because after I gave Holly her certificate, her mum said to her, "Give the doctor a hug." And as I was returning the hug, I felt Holly's healthy little heart beating away on the right side of her chest against my hand. And that hug was really one of the highlights of my clinical career. Okay, a Cnidian analysis of the second case depicts DQA in year 8 as in the denominator population for school-administered HPV vaccine according to local public health guidelines. It would prioritize the finding from randomized controlled trials that the vaccine has been shown to reduce HPV infection, which is linked to cervical cancer. It would see Amal in year 7 as due to receive the vaccine next year, like others in her cohort. A Cohen analysis would bring very different issues into frame. It would see Amal and DQA, along with their parents, as well-informed people who understand both the risks and the benefits of the HPV vaccine. But the issue at stake for them is how to avoid sending a symbolic message to friends and teachers that the girls are not chaste. They want to receive the vaccine in a way that remains confidential. And in relation to Pierre, the Cnidians would see him primarily as a case of multimorbidity, which is defined as having 2 or more long-term health conditions, with no single condition being the main one. And because he's in that group of a case of multimorbidity, he is also at increased risk of polypharmacy, which also has its definition, being on 5 or more drugs concurrently, and of adverse drug reactions, medication errors, frailty, confusion, falls. That's what we teach medical students about multimorbidity, and it's all true. The Cohens would emphasize more concrete and specific aspects of the case. They would note, perhaps, that Pierre has always been a proud man. But chronic pain and tiredness for which no treatable cause has been found now limit his functioning. His inability to perform basic living tasks places high care burden on his elderly wife. His independence and autonomy are at stake. Pierre's GP witnesses his suffering and is ready to mobilize support when the couple's independent living becomes precarious. But here's the thing. Personalised medicine of the Cohen School, which some people would equate with the warm, fuzzy heart of primary care, is of limited use if the GP's practical wisdom is not fully informed by science. This abstract category of multimorbidity, with its linked abstract category of polypharmacy, is not opposed to good care of Pierre as a person. On the contrary, good application of all that abstract evidence base is going to inform that personal care. Likewise, a knowledge of situs inversus as an abstract disease category will increase the GP's ability to target the fun and games in a way that is safe and productive. And the decision as to whether, where, and when to vaccinate our 2 Muslim teenagers is made clearer by a full knowledge of the epidemiology of HPV disease and the evidence base on the efficacy of vaccination. I want to bring you back to Raphael's picture of the School of Athens. Plato, the philosopher of abstract forms, and Aristotle, the philosopher of concrete cases, are depicted in this picture not in conflict, but in dialogue. So let's fade them back into the picture, where we see wider groups of scholars on both sides of the intellectual temple contributing to scholarly debate. We'll forgive them for not having any women in the picture, but that was the 16th century. Now, what this picture is telling us is that the moral binary that's created by pitting cold, hard precision science against warm, holistic primary care is a false one. True personalised medicine will almost always need both. But in addition, it's simply not true that this binary cleaves cleanly into scientific secondary care versus humanistic primary care. Frank Cruikshank, whose 1926 lecture was warning against the danger of over-reliance on abstract disease categories, was a secondary care doctor. And there wasn't anything unscientific about Aristotelian philosophy. He just built his science in a different way. The hospital doctors at Great Ormond Street were as troubled as I was when they learnt that Holly's parents had got the wrong end of the stick about her heart condition. Almost every public health doctor I've ever spoken to has agreed that the system should have accommodated breaching the guidelines to ensure that Amal and Deequa were protected against HPV in a way that was sympathetic to their cultural practices. Pierre's ophthalmologist was just as aware as his GP that his failing sight had to be managed in the context of his frailty and deteriorating general health. Do you know, I love this picture of productive dialogue between contrasting worldviews because I myself am a long-term survivor of precision oncology. I owe my life not just to the fact that my GP was available to me and gave me a 2-week wait referral back in 2015, but also to the monoclonal antibody that targeted the fast-growing cancer that was detected at a treatable stage. So I'm drawing towards opening this out for a bit of discussion and comment. I want to give you a cautionary note. The version of primary care that had a warm, fuzzy heart, the one that foregrounded the Aristotelian vision of personalised, holistic medicine, placing each person's illness in context in a way that took account of what was at stake for them, is fast becoming a historical curiosity. Contemporary primary care has come to look distinctly Cnidian, as our electronic records have contributed to the big data revolution. We now have an emphasis on population risk stratification, predictive analytics, disease registries, standardized care pathways, algorithmic triage, and remote monitoring dashboards. Now, this change is not bad, but it does represent a potentially sinister epistemological shift. Instead of asking what is at stake for this person, we are increasingly asking what risk category does this person fall into. In Cruikshank's terms, we in primary care are now thinking predominantly in universals. The patient becomes an instance of a disease or a risk class. More and more activity in primary care is geared to stratifying and organising these disease groups and risk classes. Less and less is geared to exercising practical wisdom in unique, concrete cases. Now, our narrative relational knowledge of individual patients is attenuating as continuity of care gives way to the codified knowledge of risk scores, consultations structured by templates and quality frameworks that tie care to measurable performance indicators. Now, these changes are arguably evidence-based, and I have to say I've contributed to some of those guidelines. But that's the point. Evidence-based practice is only one voice in the dialogue. When EBM becomes a monologue because responsive relational care has been squeezed out, that's when the system becomes unbalanced. So I want to sound a warning. With its current trajectory, primary care is moving from what Cruikshank called the clear cognition of things present to the accurate classification of things recorded. The big data revolution has brought real benefits, but every GP knows that they should be more than a protocol follower, a risk mitigator, or a data steward. We should be clear about what is lost when the particular is overshadowed. So let's return briefly to Barbara Starfield before we have a wider discussion. I put it to you that the way to safeguard the kind of personalised primary care medicine I've been talking about in this lecture, we need to revisit these definitional characteristics. Put your guidelines and your risk scores and your dashboards aside. I'm not saying they're not important. Indeed, I agree they are crucial. But I am saying that unless we deliver a primary care service where people can make first contact with us in an accessible way, whatever they perceive the problem to be, in the context of a personal relationship with a professional generalist, we will never be able to deal with what is at stake for our patients. How we do this is a challenge for which I have no simple answers, but I think that's a good place to stop and open up for discussion. So thank you very much for your attention.